ಯಾವ್ದು ತೇಜಸ್ವಿ
Shall we start, Dr. Ravindra?
ಅಟ್ಕೊಳ್ತೀನಿ
Madam, you can start. Yes, madam, please go ahead.
Good evening, everybody, and welcome you all on behalf of Karnataka Institute of Fetal Sciences to yet another wonderful lecture. Today's topic will be fetal neurosonography, technique, and normal anatomy. Other than cardio, I think this is one of the system which has a lot of nuances and needs a proper technique and anatomy before going into the pathologies. In recent times, we have had many measurements which have come up with fetal neurosonography. And I think it's very important we understand the relevance of these measurements. So we have Dr. Kamalapur today as giving us the guest lecture. Sir is working as consultant radiologist and fetal medicine specialist at Father Muller's Medical College, Mangalore. We welcome you, sir. And it's a warm welcome to all the delegates as well who has joined us at this time, at this hour. So, Dr. Murli, sir.
Good evening. Yeah. Good evening, all. Good evening, Dr. Akila, Dr. Raghavendra, Dr. Seema.
So now you are the host and you can share your screen. Very warm welcome, and we are looking forward to learn the techniques and the normal anatomy of fetal neurosonography.
Yeah, thank you. Thank you.
Your screen is visible, sir.
Now is it seen?
Yeah, it's on full screen, sir. You can go ahead.
Mouse is seen. I'm audible. Am I audible?
Yes, sir.
Yeah. Okay.
Thank you, sir. Please go ahead.
Good evening, everyone. It's been a pleasure and honor to be on this platform and share my views on this topic. So I'll be going on an overview about how to go about looking at the fetal CNS, both in first and second trimester. So we all know that the brain develops through the three primary vesicles, that's the prosencephalon, the mesencephalon, and rhombencephalon. So I'm not going deep into the very early evaluation of the brain, but I'm just going to touch upon it. So you can evaluate the fetal brain starting at 8 weeks or even at 6 to 7 weeks. And this is one slide I have put to show that we can evaluate the brain as early as 8 to 10 weeks. I'm able to see the three vesicles, the prosencephalon, the mesencephalon, and the rhombencephalon. And you're able to see the whenever you're doing a scan and you see a prominent cystic structure in the posterior aspect, it's always a developing rhombencephalon. So we can evaluate using a transvaginal 3D technique, and we can reconstruct the brain vesicles and know the anatomy as early as 8 to 10 weeks. Now, I just touch upon this slide and move to the most important aspect, that is evaluation of brain in the first trimester. Now, fetal brain in first trimester has evolved due to evolution of ultrasound technologies, probe technologies, software, the new guidelines which have come up, and it's always pushing us hard to push the limits so as to go to the next level. So in 2020, there are many guidelines. There is SWOG, there is ICRI, there is SFM, there is AIUM. There are many guidelines which states. So AIUM guidelines came up at 2020, which says that in first trimester, we can evaluate the fetal brain predominantly in axial, in sagittal, right? So in axial, we again look into the transventricular, the transthalamic, and transcerebellar. Similarly, what we in the second trimester, in the sagittal, the same section what we look for in the NT scan. The first image what we look for in the first trimester is the transventricular plane. So what we see is intact cranial vault with a complete ossification. Then we look for the midline falx. The lateral aspect of the falx, we see the two ventricles filled up by the choroid plexus. Then a part of the cerebral cortex. Now what I see in middle is the CVI, or the cavum veli interpositi. Earlier, this was termed as the third ventricle, but we see third ventricle even more down, not at the level of ventricles. So the first section, we look for the intact vault ossification, the midline falx, choroid plexus, the ventricles, cortex, as well as the CVI. Now from ventricular plane, as we go down, we go to the thalamopedunculaire or the thalamic plane. This is as similar as what we see in the second trimester. Just caudal to the deep transventricular plane. From anteriorly, I'm seeing the continuous falx cerebri, which has a slight interruption. That is the third ventricle. I go posteriorly. I'm at the level of the cerebral peduncles. I'm seeing the thalami. Posterior to thalami are the cerebral peduncles. Then I'm seeing the aqueduct of Sylvius. So this aqueduct of Sylvius to the occipital bone is another important landmark to evaluate neural tube defects. Needless to say, you're also seeing the intact ossified skull. So we've seen the transventricular plane. Then you've gone down to look for the transthalamic plane, then the transcerebellar plane. The typical appearance of a transcerebellar level in first trimester is that of an hourglass. It is found basically by the developing cerebellum, the fourth ventricle. The waist of the hourglass is by the choroid plexus, and posteriorly the developing cisterna magna. So when I take a cine loop, this is what I see. I'm seeing I'm tilted. You just see the angulation. I'm not seeing the anterior complex that clearly, but my focus is on the posterior aspect. So what I see on the posterior aspect, I'm seeing the developing cerebellum. I'm seeing the fourth ventricle, the choroid plexus, and the cisterna magna, forming the typical hourglass configuration. So this hourglass configuration gives you some sort of confidence that the posterior fossa looks fairly normal. Now coming to the next. This section is called as the tilted axial view. This is something similar to what we see in the NT scan, that posterior cranial fossa. So I'm seeing the developing brainstem. I'm also seeing the IT and the choroid plexus, which is now mentioned as the choroid bar, then the cisterna magna. This is very much similar to the posterior cranial fossa when you see the NT scan. So I take a tilted axial view through some angulation, and I get all the anechoic cystic spaces, what I see during the NT scan at the level of the axial view to the small tilt. So this I always incorporate in my study for the NT scan. Now from the axial, we move on. Then I have gone through the three major sections. So you might be wondering, it might take a lot of time. So initially, there's a learning curve involved. But once you go through the learning curve, it's just one sweep. I just have to take one sweep. That is the transventricular, transthalamic, transcerebellar. It is just one sweep, which hardly takes 10 seconds. At this stage, you are seeing the ventricles, vela interpositi. You go down below, you are seeing the thalami and started to seeing the peduncles. You are seeing the third ventricle. Go down, you are clearly appreciating the peduncles, the aqueduct of Sylvius, the distance between the aqueduct of Sylvius and the occipital bone. You go down further, you are appreciating the hourglass configuration, which is the normal appearance on a posterior cranial fossa on an axial section. So this all takes one sweep to confirm all the three views. Now from the axial, we move on to sagittal. This is a very familiar picture, what we all take during an NT scan. I don't want to go into the details. So what I want to see is you are seeing the nasal bone. You are seeing the nasal bone. You are seeing the skin. You are seeing the nasal tip, the maxilla. Then you are seeing the dancephalon, the brainstem. Then you are seeing the brainstem, the choroid plexus, the fourth ventricle, the intracranial cisterna magna, and the intracranial translucency. So this is your brainstem. This is the posterior margin of the brainstem. This forms your intracranial translucency. This forms your cisterna magna. This is your occipital bone. This is your nuchal translucency. So this criteria we all have read many times. We are quite familiar with this criteria. I'm not going to run down through this criteria. So the posterior cranial fossa is important because it gives us a surrogate marker to look for neural tube defects as well as suspect posterior fossa cystic lesions, basically a Blake's pouch or a Dandy-Walker malformation. So once you've seen the axial and the sagittal view, you go through certain landmarks. The first landmark is the thalamus and the brainstem. The next is your intracranial translucency, the cisterna magna, and the nuchal translucency. So you see 1, 2, 3, and 4 hypoechoic lines or hypoechoic spaces. If you see 3, then you suspect an underlying neural tube defect. Now going to the next one step ahead, you all have heard about IT, the intracranial translucency, which I told earlier for open spina bifida. It's absent. Absent IT is seen only in 18% of cases. It's small in 45% of cases. A meta-analysis says absent IT sensitivity as low as 53%. So recommended to use other markers to diagnose open spina bifida. One such marker is the brainstem to brainstem occiput ratio, which also gives you the status of the cisterna magna due to the underlying pathology. So this is just a distance with the thickness with the brainstem and from the brainstem to the brainstem occiput ratio. This ratio is usually less than 1. And if at all this ratio is reversed, then you have to suspect underlying neural tube defects. Even if this ratio approaches 1, please look out for a subtle defect down under. Make the patient wait for the spine to come up, and it's worthwhile taking another look at the spine. So these are the 3 lines, what you see: anterior margin of the brainstem, posterior margin of the brainstem. This forms the brainstem. From the posterior margin of brainstem to the occiput is your brainstem to occiput ratio. So this ratio in a way helps us to suspect underlying pathology, especially if it's a subtle one. I always have the habit of measuring it because sometimes we might eyeball and see it may look normal, but at times I had a case where it was just approaching 1. So there was a small neural tube defect. So it's worthwhile taking this measurement. Now, when I sum up the first semester brain, you look for the skull. The key normal feature is an oval, uninterrupted shape, uniformly hyperechoic skull. If there is a problem in this area, you suspect a crania-exencephaly sequence or a cephalocele. You look for a midline fox, which is uninterrupted. If there is interruption, in first trimester, you suspect only one type of holoprosencephaly, that is A-lobar holoprosencephaly, which is a most severe form of holoprosencephaly. The lateral ventricle and choroid plexus, although there is no such criteria to measure and say ventriculomegaly in first trimester, but yes, if usually the choroid plexus fills up symmetrically to both ventricles, if there is some space, then you suspect ventriculomegaly. Again, it is subjective and you need to call back the patient at a later stage. Posterior cranial fossa, I just spoke about the 3 similar anopic spaces. If there is any problem, you suspect Chiari malformation or cystic anomalies. Now, having gone through the first trimester, now we come back to a more similar one, that is second trimester. The second trimester scan involves the primary views, that is the transventricular, the transthalamic, and the transcerebellar. The extended neurosonogram consists of the coronal and sagittal views, that is the transfrontal, transcaudate, transthalamic, transcerebellar. The sagittal views, basically the mid-sagittal and parasagittal views. The technique basically involves use of high interplay between various transducers. You choose a high frequency transducer. The spatial resolution increase, but the penetration comes down. So you need to choose from the array of transducer based on the gestational age, the maternal body habitus, and various other factors. Usually they use a transducer ranging between 3 to 5 megahertz. Recently, you have wideband transducers, but I put an array of transducers 1-6, 2-9, 9L, the linear transducer, volume probes. You have an array of transducer which help you to cater. I can also show you if it's a breech presentation, you can get very good image quality similar to a transvaginal scan on a very good transducer, basically a 9L or a 2-9. Imaging parameters, usually it's performed 2D with grayscale. Harmonic crossbeam, speckle reduction is all utilized so as to bring out subtle details, and also in cases of patients with having a high body mass index. The basic screening, the 3 axial sections, transventricular, transthalamic, and transcerebellar. So the first section, you are seeing the transventricular section. You are seeing an oval-shaped skull with echogenicity totally normal. You are seeing nicely sutures. There is no indentation. As you come anteriorly, you are seeing the fox, which is interrupted by the cavum septum pellucidum. I go further, I am seeing the far lateral ventricle. The near lateral ventricle is obscured by the reverberations of the parietal bone. So I am appreciating the far lateral ventricle, the choroid plexus. Then I am seeing the parieto-occipital fissure. Just lateral to the cavum septum pellucidum, I am seeing the frontal horn of the lateral ventricle. Just posterior to that, the blue circle is your caudate nucleus. Then you have the thalamus. Then you have the lentiform nucleus. Now, just seeing one ventricle is not sufficient. You need to always see the near ventricle. To that, you need to tilt 45 degrees so that you get to see the near ventricle, and you need to measure both the ventricles. That's done basically to suspect in cases of asymmetric ventriculomegaly. Just seeing one ventricle is not enough. You need to look both for the distal as well as the near ventricle. Now, going one step down, I'm coming to the transthalamic section. What I see is again the anterior fox, which is interrupted by the cavum septum pellucidum. Then I'm seeing the frontal horn of the lateral ventricle, which flank the cavum septum. I go posteriorly, I'm seeing the third ventricle. Then I'm seeing the two thalami, right? Just laterally, I'm not seeing the posterior fossa. I'm not seeing the cerebellum, right? I'm not completely seeing the ventricle, but I'm at the level of the two thalami. And this forms what is called as anterior complex, which I'm going to deal in subsequent slides. Just inferior to transthalamic level, you do get to see something similar to cavum septum, but here it's not interrupted. You're seeing the falx. The falx is uninterrupted, right? And these are the fornicial columns. Okay, these are the fornices. This is not cavum septum. Please don't mistake this for the cavum septum pellucidity. And one clue is that the anterior falx is not interrupted, unlike the actual CSP, which interrupts. You see, the falx gets interrupted. Here, there is classical cutoff. That cutoff is absent. It is continuous. This is the fornix, right? At this level, what I want to show is also the hippocampal gyrus. I'll come back to that. So slightly inferior to the thalamus, what I want to show is you are nicely seeing the two thalami, but this is the place which is not completely transcerebellar, but slightly inferior to the transthalamic plane. I'm seeing the various cisterns. So these are the cerebral peduncles. This is the thalami, the two thalami. These are the cerebral peduncles, and in between the two peduncles are the interpeduncular cisterns. On the lateral aspect, on both the sides, you find the ambient cisterns, and posteriorly is the quadrigeminal cistern. Just lateral to the ambient cistern, you find the hippocampal gyrus. And you are partly seeing the cerebellum, but not completely. So this is slightly inferior to the thalamic level. You are completely seeing the anterior complex. Now I go down and do the proper transcerebellar section. You are again seeing the anterior falx interrupted by the cavum septum pellucidity. An important clue to tell you are at the level of CSP is it's always flanked by the laterally by the frontal horn of the lateral ventricle. So in all the three sections, axial sections, one important structure which is always seen is the cavum septum pellucidity. You need to appreciate cavum septum pellucidity that serves as a marker to avoid erroneous measurements, erroneous sections, and so forth. So I am able to see the cerebellum, which is a dumbbell-shaped structure, which has hypoechoic lobes, and in between you find the hyperechoic band-like structure, which constitutes the vermis. So at this section, you measure the transcerebellar diameter from lateral edge to edge. Then posteriorly, from the outer edge of the cerebellum to the inner edge of the occiput, that constitutes a cisterna magna. From the outer edge of the occiput to the outer edge of the nuchal fold, that constitutes the nuchal fold thickness. So you have the anterior falx interrupted by the CSP. You go below, you are seeing the cerebral peduncles. Then you're going back, you're seeing the cerebellum, the vermis, then the posterior fossa structures, basically cisterna magna and the nuchal fold. Now coming to the one structure what we always see is called the anterior complex. In some reports, you might have seen that they mention as anterior complex appears normal. So what constitutes anterior complex? It is the interhemispheric fissure, the genu of the corpus callosum, the callosal sulci, which is nothing but a pile reflection of the outer aspect of the corpus callosum. Then you also have the head of the caudate nucleus. Then you have the thalama. So all these things, structures, constitute what is called as the anterior complex. If all these structures appear normal in a neurosonogram, you can as well as mention and structures of the anterior complex appear normal. You can also go ahead and in detail explain the various structures. This was the columns of fornices which I was telling. Kindly see that the anterior interhemispheric fissure is obstructed by the genu of the corpus callosum and the CSP, unlike the columns of the fornix, which is continuous, which is not flanked by the anterior horns of the lateral ventricle. You can appreciate the CSP, which is flanked by the anterior horn of the lateral ventricle, but you don't find the frontal horns flanking any structure here. So these are columns of fornices, which not to be mistaken for cavum septum pellucidity. Now coming to what constitutes the posterior complex, similar to anterior complex, you have the choroid plexus in the atria of the LV. You have the posterior horn of the lateral ventricle. You have the parieto-occipital fissure. and the posterior interhemispheric fissure. So it's in your axial sections, you make a checklist. You need to check on all these structures: the anterior complex, the posterior complex, the sulci. You need to see the right from the outer aspect at the skull ossification. When you go down inside, you need to have a checklist in your mind. There are a lot of protocols you can follow. Now, what constitutes extended evaluation? Now, we are done with the basic screening of the brain. Now, what constitutes an extended neurosonogram? Why do you do it? There is suspicion of a CNS or a spinal malformation on a routine ultrasound. That is one entity. You have a problem in your NT scan. The CNS or spinal malformation, increased NT. Family history of inheritable CNS or spinal malformation. Previous pregnancy had a CNS malformation. Fetus with congenital heart disease. Monochorionic twins, infection. Most important, exposure to teratogens which affect neurogenesis, and chromosomal microarray findings of unknown significance. Now, what constitutes a extended neurosonogram? Just like MR, which gives images in all planes, in extended neurosonogram, we need to evaluate in axial, coronal, and sagittal sections. Now, in the coronal views, we look for the transfrontal, the transcaudate, transthalamic, and the transcerebellar. In the sagittal views, we look for the mid-sagittal and the parasagittal views. The coronal views, visualization of the transfrontal plane is anterior to the anterior fontanelle. The transcaudate is obtained through a more posterior approach, tilting or sliding the transducer towards the posterior edge of the anterior fontanelle. The transthalamic plane is relatively close to the transcaudate plane. It is obtained sometimes through the anterior fontanelle by angulation of the probe, and sometimes through the open sagittal suture. And the transcerebellar plane is the only coronal plane that is obtained through the posterior fontanelle. These are the 4 coronal views. Now, going into the details, the first section you cut anterior to the ventricular system, that to the frontal lobe. So you see an intact interhemispheric fissure. Just posteriorly, you look for the transcaudate plane. Far posterior, you see the 2 rounded thalami. You are at the transthalamic plane. Far posterior, you are looking at the occipital lobes. That is the transcerebellar plane. Now, coming to the transfrontal plane, this is a transvaginal ultrasound image with VCI construction, and this is a transabdominal section taken on a 9L transducer, linear transducer with a breech presentation. So what you see, you look for the intact skull, you see intact interhemispheric fissure, you look for comma-shaped frontal horns of the lateral ventricle, and you look for the orbits. So these are the structures what you see in a transfrontal plane. Uninterrupted falx, comma-shaped lateral ventricles, the orbits, intact skull. So this is what, because the section cuts through the frontal lobe. So that is what you're seeing, the uninterrupted falx. Going still behind, you're at the level of the caudate nucleus. Here, what happens? The falx gets interrupted. You are seeing a part of the skull, you are seeing the subarachnoid space, you are seeing the interhemispheric falx, right? Interhemispheric fissure gets interrupted by the genu of the corpus callosum. Just inferior to that, you have the caveum septum pellucidum. Flank lateral aspect of the CSP, you find the frontal horn of the lateral ventricle, which have comma-shaped structures. And then you have the caudate nuclei on the other 2 sides. You're also seeing part of the lateral formation of the lateral indentation. And this is the region of the suprasellar cisterns. So when you're at the level of the caudate nucleus, you see a part of the intact skull. You are looking at the interrupted falx. Interruption is by the corpus callosum and the CSP. Then you look for the 2 frontal horns of the lateral ventricle. Then you're looking at the part of the subarachnoid space. Then you're also looking at the suprasellar cisterns. So you've gone through the transfrontal plane, uninterrupted falx, going back towards the transcaudate plane, where you look for the caudate nuclei and all other structures. And this structure, what you see is the callosal sulci, which is nothing but a pile reflection along the outer aspect of the corpus callosum. Now I go still backward and I am seeing seeing the callosal sulci, the interrupted falx, the body of the corpus callosum, which is flanked by the frontal horns of the lateral ventricle, part of the cavum septum. Then what I am seeing is the two rounded structures, which is the thalami. I am also appreciating the lateral angulation or the lateral fissure on both the sides. So at this stage, I am looking at not only the structure of the anterior complex, I'm also looking at the thalami. I'm also looking at the lateral fissure. So this, I'm also appreciating a part of the subarachnoid space. I'm also appreciating the cortex, the surface of the cortex, which does help us a lot in cases of cerebral cortical malformations, maybe in late second and third trimester. Now moving from transthalamic, I go still posteriorly, which is this is the only section which has to be taken through the posterior fontanelle. Again, these are not transvaginal, both are trans-abdominal images. This is on a 2-9 probe. This is on a 9L linear transducer. So this one, you are seeing the intact occipital bone. You are seeing the two occipital lobes in the occipital horns of the lateral ventricle. In the midline, you are seeing two indented sulci coming out. They are called the calcarine sulci. Then just posteriorly, you are seeing the dumbbell-shaped structure, which has two hypoechoic lobes on either side and a hyperechoic structure in between. So this is a classical appearance of a cerebellum, where you see hypoechoic lobes of the cerebellar lobes, and the hyperechoic midline structure is nothing but the vermis. So you can nicely appreciate the anatomy even on a trans-abdominal probe. But yes, if it's a breech, if it's a cephalic presentation, you might have to go with a transvaginal scan. You have to look in for doing an extended neurosonogram. But if it's a breech presentation, you can go ahead and do a decent scan and pick up anomalies. Now coming to the sagittal sections, sagittal sections are usually two. One is at mid-sagittal. It's not exactly mid-sagittal, usually cut across either of the thalami on the right or left. Then you have the parasagittal section. So the mid-sagittal section is very important. You see a lot of structures. You need to go through supra and infratentorial anatomy. The anterior aspect, you go through the anterior of posterior fontanelle, or even through the non-ossified suture, depending on the area of interest. Again, you need to have gentle manipulation. At times, when you're doing a transvaginal scan, you need to push a little bit with your free hand so as to fix the head. The mid-sagittal section is obtained not only in anterior, it's also obtained on the posterior section. But yes, if you're evaluating infratentorial structures, it's always the posterior fontanelle which is preferred. Now, before going into the structures, I would just like to look into the mid structures which form the mid-sagittal plane. One such structure which draws everybody's attention is the corpus callosum, right? What is corpus callosum? Corpus callosum, it consists of around 200 million white matter fibers, which are densely myelinated, which cross across the hemisphere, transferring vital information, motor, sensory, and cognitive. So that is one structure, what you see. It has the rostrum, genu, body, and the splenium. Just in the subcallosal area, you find is the cavum septum pellucidum. Then you go down, you find the thalami, the brainstem, the fourth ventricle, the cerebellum. So this is the structure. This structure is what we try to replicate on an ultrasound, right? So this is again the part of the band-like structure, that is the corpus callosum. Then just below you find the third ventricle, right? Then what you see on ultrasound, you're looking for the thalamus. You're come down, looking at the brainstem, the fourth ventricle, the cerebellum, and the corpus. So going into the image, this is a transvaginal image, which is VCI, volume contrast imaging, generated vaginal image on the sagittal section. Now, what you see, so you cut across in the midline on either side. So you see something which is very shining here, the medial aspect. So that is nothing but the falx. So this shining structure, what you see in the midline, is nothing but the falx, right? You are seeing the, I'm indenting around the anterior fontanelle. I'm looking at the partly at the cerebral parenchyma and the contour. Then I'm seeing the shining structure which represents the falx. Then I see a curvilinear C-shaped structure which is hypoechoic and which is having hyperechoic bands on either aspect, traveling from anterior to posterior, which is known as the corpus callosum. This corpus callosum has the rostrum, genum, the body, anterior aspect of the body, posterior aspect of the body, and the splenium. An important aspect, when corpus callosum is completely developed by around 20 weeks, the splenium always abuts the tectum of the midbrain. So that landmark one you should always remember. The splenium of the corpus callosum always abuts the tectum of the midbrain. Coming from anterior, you are seeing the corpus callosum, right? Just below the corpus callosum, you have a cystic structures, which is called as the cavum septum pellucidum. We'll come back to that later. Now coming down, I'm seeing a C-shaped hyperechoic structure, which is little broadened posteriorly and tapering anteriorly. This constitutes the tila choroidea, which forms at the roof of the third ventricle. So third ventricle is nothing but a slit-like structure between the two thalami. So I'm cutting across it and I'm seeing part of the thalami here. So you find a slit-like structure in between the two thalami. Above that, you find the tila choroidea. Just going behind the tila choroidea, then what you find is the thalami. The thalami comes down caudally, continues imperceptibly into the midbrain. The midbrain. How do you identify the midbrain? Through the bump. So this bump is nothing but the tectum of the midbrain. The midbrain continues imperceptibly into the pons. The pons is found by the identified by the ventral belly. The pons continues as medulla oblongata, right? So go further. Just posterior to the pons, you find a bright kidney bean shaped structure, which is shining in the infratentorial compartment or the posterior fossa. Is nothing but the vermis of the cerebellar hemispheres. How do we describe the vermis? It is a kidney shaped structure which has a medial as well as the inner or the outer dorsal or the ventral margin, the dorsal margin. The ventral margin has an indentation called as the fastigium. The dorsal margin has an indentation. This is the indentation which constitutes or divides the vermis into upper 1/3, superior lobe, lower 2/3, inferior lobe. When you can appreciate the primary fissure, indentation, the fastigium, the division into two lobes, you are rest assured that, yeah, this cerebellum looks normal. If you are still in doubt, you can go ahead and do a biometry. You can take craniocaudal and anteroposterior measurements. There are normograms you can check always and go to rule out vermian problems. So in a sagittal view, I'll repeat once again. Yeah, another important aspect. This tila choroidea ends anteriorly at the level of foramen of Monro. So it forms this line. What lies anterior to this line is the cavum septum pellucidum. What lies posterior to this line is of cavum burgae. So the anterior margin or dipping of the tila choroidea is a point of division between the cavum septum pellucidum anteriorly, cavum burgae posteriorly. So I'll revise this once again. You're seeing the occipital bone. Medially, you're seeing shining surface. Medially, that's nothing but the falx. Then you're seeing a C-shaped curvilinear structure, that is the corpus callosum. A line which divides or meets the anterior margin of tila choroidea, divides the subcallosal space into a cavum septum anteriorly, cavum burgae posteriorly. You are looking at a bright C-shaped structure sitting on the thalami, is nothing but the roof of the on the roof is a tila choroidae of the third ventricle. This continues posteriorly and has a broad margin. Then just below the tila choroidae, you have the thalami, which continues imperceptibly into the midbrain. You can appreciate the tectum of the midbrain. Go down, you're appreciating the pons and its ventral belly. Just posterior to the pons, you find the cerebellar worms. Another important structure is where you can have fluid accumulation or cyst is the cavum vela interpositi. Right? This is the which is found just at the level of the splenium. So these are the important structures which we usually see on a mid-sagittal section. We do a transvaginal section. Now, from mid-sagittal, we move on to the parasagittal section. Now, what happens in a parasagittal section? We are looking at the intact skull, then we are looking at the subarachnoid space, then the cerebral mantle, right? It is also called as a trihorn view, where I am seeing the frontal horn, the body, the posterior horn, and the inferior horn. All the three horns. You are seeing the choroid plexus filled with the ventricle. You are seeing the contour of the cerebral parenchyma. And this section helps us especially in late second and third trimester to rule out cortical malformations, periventricular nodular heterotropias. Cortical malformations, very important. If it is breech, you can go ahead and do a 2-9 or a 9L probe. If it's a cephalic presentation, then nothing like doing a transvaginal scan. Then I'm also appreciating the inferior horn of the lateral ventricle, the posterior horn, the anterior horn, and the choroid plexus filling the ventricles. At this region, I'm also seeing the thalami, the rounded structure called thalami. For sagittal, you look for the midline and the parasagittal section. The role of Doppler, you apply Doppler in the third trimester to look for the MCA, right? And in cases of neurosonogram, you apply Doppler to look for the pericallosal arteries. So this is the corpus callosum, right? And you are nicely seeing the pericallosal arterial network, which is following or hugging the corpus callosum. And here you are appreciating the two middle cerebral arteries and the circle of Willis. So these are the two applications of Doppler when it comes to the normal sonogram. Another application is to identify the optic chiasma, which can be seen either in axial section, which is an orbitothalamic section. I have not included that. And another is a transcaudate section. Now coming to the spine. Spine is again seen both in first and second trimester. So in first trimester, you can appreciate a spine both in coronal as well as the sagittal section. Now what we appreciate in the coronal section is there is no lateral angulation or scoliotic deformity. There is tapering of the spine. And on a sagittal section, we are seeing skin covering the spine. And I am seeing vertebral bodies, and I'm more interested to look for the intact skin covering the spine. So I just take a sweep. I'm just taking a coronal sweep. This sweep is considered as a very highly productive sweep in cases of not only seeing the spine, but many structures. So what are the structures I see? I'm seeing the stomach, which is in the abdomen. I go posteriorly, I'm seeing the two kidneys. I go more posteriorly, I'm seeing part of the spine, which shows no scoliotic deformity. I'm seeing the kidneys. And here I'm seeing the tapering of the spine, which completes not only looking for the spine, but also for other abdominal structures. And again, in this case, I'm appreciating the skin covering the spine, I'm appreciating the stomach. I'm also completely seeing the vertebral bodies, right? I'm seeing the diaphragm, I'm seeing the stomach bubble, the lung fields. Then I'm seeing the bony elements of the spine. I'm seeing the skin covering the spine, right? So you're completely able to appreciate the vertebral bodies of the spine. So your coronal sagittal sweep in first trimester covers your entire evaluation of the spine. Now coming to second trimester, I have an interesting tip. So there's something called CRI and SRI in your machines. When you're looking at spine, you turn off the CRI and SRI, you will see the bony elements better. you are seeing the bony elements better. When you turn it on, you are seeing the soft tissue better. You are seeing the spinal cord. You are seeing the skin, which is not appreciated. I'll show it in another image. But if you want to look at the bony elements of the spine, turn off CRI and SRI. If you want to see the skin covering the spine, you want to see the cord, you just turn on the CRI and SRI. So these are the three images. This the first and the third one, you have the CRI and SRI on. What you are seeing is a very nice intact skin covering the spine, right? But here you are able to appreciate the skin, but you are able to appreciate the vertebral bodies and the curvature much better than the first and the last image. So always have two settings to look for the spine, one for the bony elements and the other for the skin covering the spine. So going further, when you apply the CRI and SRI, you are seeing the intact skin, right? You are seeing the bony elements and forming upturning of the spine. This upturning is very important because in case of sacral agenesis, this portion is abruptly cut off and this is not seen. So this can be a subtle finding. Sometimes it can be tricky, but if you are in the habit of seeing upturning of the spine covering by the skin, you are sure, yeah, you're not missing on a sacral agenesis. Now coming anteriorly, I am seeing the spinal cord, I'm seeing the cauda equina, I'm seeing the phylum terminale, and I'm also seeing the neural canal. So you can appreciate subtle important structures. And in cases of tethered cord, you can appreciate, you can count the level of the conus medullaris, and you can also appreciate the neural canal, which is obliterated in a tethered cord. So you are appreciating the conus medullaris, the phylum terminale, then you are appreciating the neural canal. You are appreciating the upturning of the sacral spine, intact skin. This completes evaluation of the lumbosacral region of the spine. Now going further, the coronal spine, these are usually done to evaluate for diastematomyelia, hemivertebra, and also scoliotic deformities of the spine. So you can also appreciate the spine at the level of the body, posterior recesses, at the level of the lateral masses, in the three aspects. You can appreciate the tapering of the spine here, the sacral tapering. You are appreciating the iliac blades. There is no, again, this is CRI and SRI on. You're not appreciating the vertebral bodies, but here, yes, you're appreciating the vertebral bodies better. There is no any abnormality. There is no scoliotic deformity. You can appreciate the spine in all the three, the vertebral bodies, lateral arches, and at both levels. Now, again, the axial section. The axial section is basically to see another important view, to look for the skin covering the spine. You are appreciating the lateral masses. Most importantly, you are seeing the spinal cord and the cervical, in the thoracic as well as the lumbar section. But you go down the sacral section, you are seeing the iliac blades, the sacral, but you're not seeing the cord. So when you're looking at the axial section, which should be done in all cases, you look for continuity of the skin, you look for the cord. Very important to look for cord splitting in diastematomyelia, the axial section. And another important section is in cases of chondrodysplasia punctata, you look for splitting of the vertebra, the vertebral processes. That is very important in cases of chondrodysplasia punctata. And even in case of diastematomyelia, you find echogenic mass. You want to rule out cord splitting. This is the section you have to run down to look for the actual level of the cord splitting. Now, take-home points, standard protocol to be used while performing the scan. A 2-9 or 9L transducer gives very good results if the baby is persistently in breech position. Coronal sagittal views are to be looked for only if there is suspicion of abnormality in primary views. In case of an abnormality, more than one plane to be obtained for better understanding. The operator should have knowledge about the correct technique, anatomy of the brain and the spine. And I would like to tell, you need to always have another person when you're doing a neurosonogram, especially if it's TVS. You need to fix the head at some point of time, and then you need to maneuver the probe so as to get the best views to diagnose the anomaly. I thank KIFS for giving me an opportunity and to share with you my views. And I'm happy that I could make some time and share my views on first trimester and second trimester brain and spine. And I have not covered the individual sulci, the medial convexity sulci, middle hemispheric sulci, as it's a longer process. And in future, we'll be going ahead with the more detailed presentation. Thank you.
Thank you, Murali sir, for such a great presentation. And I think knowing the techniques and normal anatomy is very important to identify the pathology. Making full utilization of the machine which we have, that is also equally important.
Yeah. We need to sit down with the application specialist for at least 3 to 4 days, at least 2 to 3 times at different times to utilize all the, for what we are paid. We are paid for all the softwares, probes. We need to utilize them. So it is their responsibility that they have to come and show us all the possibilities. Only then we can utilize the machine.
Yes, sir, and try it on different patients depending on their parietal wall thickness.
Yeah.
Yes. So sometimes it becomes so that we see the images, we are able to diagnose, but when the probe is in our hands, follow those techniques and get those planes is what is more important. So a regular practice will help us in understanding the normal anatomy, which makes it easier to identify the pathology. Without knowing the normal anatomy, identifying the pathology would be very difficult. So I think it's like a foundation we have today, that normal anatomy is very important. There are a few questions, sir. Do we mention K1 Varge? Does K1 Varge and CVI need to be reported? Hello? Okay, I think I need to unmute, sir.
Yeah, K1 septum, K1 Varge need not be reported. It's a normal phenomenon. We don't have to report. It appears prominent. It looks something very scary. And if at all clinician does the habit of seeing images, if they ask something, you can just tell them. And I don't report if it's a K1 Varge.
Yeah, it's a part of the normal K1 spec. Yeah.
Sometimes it looks scary, but it's fine. It's a normal.
We need to know that so that we don't confuse it with any pathologies.
We should know the criteria to diagnose K1 Varge, right? And we should also know the differential diagnosis about what other structures can form there, right?
Yes, sir. Yes, sir. Thank you so much.
Yeah.
I think the pathologies of fetal neurosonography, and until then, let's all practice these techniques and planes so that we'll be able to follow it up with the pathologies which we can identify.
Yeah.
Thank you so much, sir, for your presentation.
Somebody asked about CVI. I'll just put it in the group. The cavum velum interpositive cysts are present, CVI cysts. It is seen just posterior to the splenium of the corpus callosum. That is the potential space where you find the CVI cysts, right? So I'll just put in the group about a CVI cyst. It can be seen on axial section, right? And also seen in a sagittal section, just posterior to, if no need to mention CVI in the report. CVI cyst, if it's present, you need to mention it. Cavum velum, cyst of the cavum velum interposity in the second trimester, if you see. It is seen as a small cystic structure posterior to the splenium or at the region of the splenium. If it is present, you do mention it as a CVI cyst, but there's no harm. It is not going to harm the fetus. That's okay.
Thank you, sir. Thank you so much for the presentation and your time.
Thank you.
Let's wind up for today. Good night and thank you, everyone.
Thank you. Thank you all.